and I'm a DPhil student in clinical neurosciences at the University of Oxford at Jesus College. We welcome you all to our talk organized by the Ventilator, Weaning, and Extubation in Neurocritical Care Network affiliated to the Nuffield Department of Clinical Neurosciences. So today's talk is on extubation in neurocritical care patients, focusing mainly on epidemiology and clinical factors. Our speaker is Professor Raphael Cinotti. Professor Cinotti is an MD, PhD, and a professor of anesthesia and critical care at the University Hospital of Nantes and University of Nantes in France. He manages supervision of clinical research in anesthesia and critical care in the department, and is also the current head of the French Society of Anesthesia and Critical Care Research Network. He also is the coordinator of the ENIO, which is Extubation in Neuro-Intensive Care, an association with Outcome International Network, wherein they conducted an international prospective observational study in 73 intensive care units in 18 countries from 2018 to 2020. And I think around 1,500 patients included in the study. So we are so glad to have you, Raphael, and we look forward to your talk, and over to you.
Thank you very much. Good evening, good afternoon, everybody. So yes, my name is Raphael Cinotti. I work in the University Hospital of Nantes in France. And the topic today is about the weaning of invasive mechanical ventilation and neuro ICU patients. I have no conflict of interests about this presentation. First, we will have a quick overview of the subject about extubation failure in the critical care setting. This was a national multi-center study performed in, I would say, 25 ICUs in France. A couple of years ago, the authors have gathered information about extubation failure in a really broad ICU setting. We included medical ICU patients, surgical, trauma, neuro, etc. And if we are interested in the general ICU population, you can see that the extubation failure rate at 48 hours after extubation attempt reached 10%. And on the right side of the slide, you may see the risk factors associated with failure. And the reason for admission in the ICU for a coma with no specification about the what's beneath it was an independent risk factor of extubation failure, stressing that very likely neuro ICU patients are at high risk of extubation failure during the weaning process. And indeed, we have specific data in neuro ICU patients. Some of them were stressed in year 2000 by some teams. This was a single center study in which the authors identified that the extubation failure rate was around 16%. So indeed, quite a higher rate than in the general ICU population. And there was obviously some interest, again, at the beginning of the 21st century in the year 2000. This is another cohort. It was a prospective single center study in which the authors were interested into two interventions regarding the extubation in neurocritical care patients. You can see that in this cohort, they had a mixed neurocritical care population with TBI, subarachnoid hemorrhage, and stroke, which I would say a rather standard population, young patients with a mean age around 40 years old, and a Glasgow coma score at admission below 8, which is quite standard, I think. And they were interested mostly in if we waited long enough for the patient to recover an adequate or high enough level of arousal. This was classified as a delayed strategy of extubation versus a non-delayed strategy in which patients displayed lower Glasgow coma score at extubation. And so when they compared these strategy. You can see there were several clinical differences at extubation between the two populations, with obviously higher Glasgow Coma score in the delayed strategy, some clinical assessment such as a specific dedicated airway care score they had created, which was higher again in the group of the delayed strategy, and other relevant items and features such as cough and the gag reflex. And which is very interesting and was stressed so in the study is that the extubation failure rate was quite similar, or at least there were non-significant differences between the delayed and the non-delayed strategy. So you can see that the extubation failure rate was around 17%. And so it seemed not relevant, even 20 years ago, not to wait too long for the patient to recover, because it was not associated with higher success. And interestingly, the delayed strategy group showed higher morbidity with a higher rate of health-acquired pneumonia, higher ICU length of stay, and hospital costs. So definitely a strategy that would seem at first point relevant, meaning wait for the patient to recover a better clinical situation. Well, definitely it was not a good call and probably is not a good strategy in this specific high-risk population. A few years after, we are now reaching year 2008. This was a single center study in which the authors tried a systematic extubation strategy when patients had a combination of a Glasgow score of at least 8 and an audible cough when trying endotracheal suctioning versus a standard of care, and patients were randomized in the systematic intervention, meaning systematic extubation, as long as these two clinical features were met, versus a control group. As you can see, they randomized almost 100, a bit more than 150 patients in each group. I wouldn't say it was a classical, I see a neurocritical care population, meaning that they indeed include severe patients with subarachnoid hemorrhage and head trauma, but I think they have a very high rate of patients following a cerebral tumorectomy after brain neurosurgery. As you can see, almost 1/4 of patients in this population were postoperative patients. So I think it's a quite specific population. And which was interesting is that in the intervention group, the higher extubation failure rate was lower. But this is a puzzling result for me, because there were no differences in other endpoints, meaning that the duration of mechanical ventilation was the same in both groups. So as this was, of course, an open trial, there was no blinding in any way. I'm not so sure how these findings, could be replicated in other settings. So it could be interesting to standardize our procedures and to have a more direct and systematic approach, but I'm not sure this study has the ability to demonstrate strongly these results. More recently, we have data, 3 different cohorts that have studied this topic. First, we did a multicentric cohort in 4 university hospitals in the western area of France. We included a bit more than 400 patients. And as you can see, the extubation failure rate was around 22% in our work. And I would say we have a more classical neurocritical care population with both TBI patients and patients undergoing stroke and intracranial hemorrhage. Again, I think this is a kind of classical, because the mean age, as you can see, is quite lower than in the general ICU population, and patient had very low comorbidities, which is a bit again common in the neurocritical care. I mean, at least in trauma patients. I must stress at this point that our definition in this study was a bit one of our own, meaning that we indeed considered patients with reintubation after extubation attempt as a failure, but we also classified patients with a late tracheostomy as extubation failure. But we would probably be able to discuss this more into details after the presentation. It was the main reason we chose this is because we never practice early tracheostomy, and we always do late tracheostomy in the setting of patients with severe neurological impairments. We were able to identify 4 risk factors, and then we were able to elaborate this extubation worksheet, which is very simple to use at the bedside, with 4 items. One is a non-modifiable factor, which is a younger age, less than 40 years old. And 3 are clinical factors that are obviously modifiable if the evolution of the patient is positive. That were the ability for the patient to follow an item or the work staff around his room as visual pursuit, the ability for the patient to perform attempts, and an evaluation of the Glasgow Coma score at the bedside of more than 10. But again, I think we can discuss this at how we evaluate Glasgow Coma score in intubated patients. One factor counted as 1, and as you can see on this diagram, a score of at least 3 was associated with an extubation success rate of more than 90%, if I'm not wrong. We were also able to delineate, once again, or as many other authors have stressed, that extubation failure is associated with higher morbidity, meaning duration of invasive mechanical ventilation, the longer ICU length of stay, and still in univariate analysis, a higher in ICU mortality rate. This was another work which was also performed in France, in Clermont-Ferrand. This was a single center study in which the authors included roughly 150 patients. Again, I would say a quite typical neurocritical care population with mixed trauma and neurovascular pathologies. Regarding comorbidities, again, I think it's quite common in this type of population. And as you can see here, the extubation failure rate was even higher than in our study because it reached almost 30%. But again, the definition here was different than ours because the authors considered that the use of non-invasive ventilation after extubation attempts was classified as a failure. That's for one. And another reason is that patients undergoing surgery for any type of surgical or radiological intervention would be considered as a failure. So you can see there are major differences in this definition. Nevertheless, the authors and colleagues were able to identify quite similar risk factors for extubation failure, success, whatever. Again, the patient ability to secure his or her airways with clinical evaluation of cough, again, swallowing attempts and gag reflex were positively associated with success. And another evaluation of the level of arousal, which we identified as a visual pursuit. And here was more thoroughly explored with the coma recovery scale, specifically targeting the visual item. And again, the colleagues were able to create and propose this worksheet, which is also, I think, very useful at the bedside. And sorry, as you can see, as the the score is high and reaches a value, a threshold of 10 or more, the extubation failure rate decreases dramatically. So I think it's quite useful to have these scores at the bedside. And finally, they also identified extubation failure as a risk, as a significant association, again, in univariate analysis with the duration of mechanical ventilation and ICU length of stay and mortality. They also were able to gather a bit of functional outcome after discharge with the Glasgow outcome scale, which, as you can see in this table, is associated with a worse outcome in the failure group. However, I must really, I would be very precautious about this result, because I don't think the analysis was properly done. To my mind, it's not possible to use the Glasgow outcome scale as a continuous variable as it is shown here. So I think this result must be very carefully interpreted. And finally, we have a third cohort, which is a multi-center study in Canada. And I must stress that all cohorts were not coordinated. We had quite no info that they were all going on in this kind of the same time frame, and all went to publication the same year, but they are really independent patients, of course, in Canada. Again, you can see that this is a quite typical mix or general neurocritical care patients with trauma, subarachnoid hemorrhage, etc. And I would say quite common characteristics at baseline regarding Glasgow Coma score, Apache 2 score, and whatsoever. So I wouldn't insist on that. But interestingly, again, some similar patterns are found from one cohort to another. Again, higher age was identified as a risk factors for failure. The baseline Glasgow Coma score was also associated with failure. The existence of cough was associated with success, and a positive fluid balance, meaning a weight increase or fluid overload in the previous days before extubation failure, was associated with failure. So this is a general finding, I would say, a general pattern, which is not specific to neuro ICU patients, but which should be very interesting to keep in mind, as it is, I think, something we can target with clinical intervention. And finally, the authors also stressed that extubation failure was associated with higher morbidity and mortality. So definitely, it is something we must care about and should target to improve outcomes. But the issues, it is important to stress in all the previous publications I have just shown, is that, as I said, the definitions were very, very different from one study to another. I will not get into details, but as I said, we use tracheostomy, some colleagues didn't, some use non-invasive ventilation, etc. There was no consensus in these studies regarding the time frame which we had to consider extubation failure. Is it 2 days after attempt? Is it 5 days? This is also subject to debate. One of them was a single center study, and we did not have extensive clinical evaluation the day of extubation. So all these reasons may explain why some findings are similar, but there are major differences. And the main methodological issue is that there are no validation cohorts, which means that it is impossible to be sure that these findings could be generalized in other settings. So they brought interesting data about the epidemiology, but still a lot of work to do in order to have ideas on what to do and what not to do. So this is why we propose to elaborate this international and observational study about the weaning and extubation in patients with acute brain injury in order to manage these flaws. The inclusion criteria in the cohort were quite large. Patients had to display a Glasgow Coma score of less or equal than 12 at baseline. They had to undergo invasive mechanical ventilation for at least 24 hours, and they could display any type of neurological insult, trauma, ICH, etc. We decided to exclude resuscitated cardiac arrest, Guillain-Barré syndrome, myasthenia gravis. Let's say that all neurological pathology without any brain CT scan anomaly, we would not consider these patients in our work. So in the end, as Joseph Aron said in the beginning, we were able to put this network on foot from June 2018 to October 2020. In spite of the COVID pandemic, which has slowed down the inclusions, we were able to gather 73 ICUs in 18 different countries. And you can see here on the map, we had many centers in America from north to south, and very active teams in Mexico. Of course, there was a strong participation in Europe, all across Europe, a bit of participation in North Africa and the Middle East with Qatar in red. And we also had a couple of countries in Asia with India and Japan, especially being very proactive. This is the flow chart of the study. We were able to, in the end, include 1,512 patients, which were separated in 3 different groups. One group with extubation failure, one group without, 962 patients, and one group undergoing direct tracheostomy, and we will get back to this afterwards. Roughly 20% of patients never underwent any attempt of extubation of any kind. The first step was to be sure how we could grasp the vast majority of extubation failure, because as I said, there's no consensus about the time frame in the general ICU literature. You can see 2, 5, 7 days. For the moment, I would say that there's a consensus, or at least an agreement that five days is quite good, but in neuro ICU we didn't have any idea. So we decided to pick up the time frame that could grasp and screen at least 90% of extubation failures, and hope, as a matter of fact, it came out that the best time frame for this was 5 days. And in the end, the extubation failure rate in this population, when you exclude tracheostomy patients, I mean patients who underwent direct tracheostomy with never any extubation attempt, the extubation failure rate is high, ranging a bit more than 19% of patients. You can see in the table the causes of extubation failure. They were just declarative for investigators. You can see these were the items at the investigator's disposal, and you can have mixed causes of failure. The most common one is, I would say, a mix of neurological and respiratory failure. You can have then upper airway failure, but again, it could be mixed with neurological cause of failure. And then with very lower rates of failure, cardiac failure, which is, I would say, quite anecdotic in this population. And from time to time, patients must undergo surgery, but again, this could be for a neurological cause and neurological impairments. Here's a bit of details. Here are a bit of details about the population. I think, again, this is a quite common neurocritical care population with TBI and neurovascular patients mostly. As you can see, regarding comorbidities, hypertension was the most common one, around 30% of patients. And we have the details, but I will not state and explain all of them because it's quite a long list. We have details about the baseline Glasgow Coma score and what were the main neurological treatment in these patients, meaning ICP monitoring, intracranial neurosurgery, decompressive craniectomy, etc. The day of extubation, we asked investigators to perform a systematic evaluation. We had information about, I would say, general ICU management. For instance, did the clinicians stop enteral feeding? Did they perform cuff leak test, and therefore did they administered corticosteroids for post-extubation stridor prevention? And we had also afterwards a more systematic neurological assessment with the presence of gag reflex, the presence and strength of cough, the evaluation of the Glasgow Coma score, and we were very careful about the quantification of each item of the Glasgow Coma score, because the verbal item is always quite challenging in intubated patients. And all the features we had identified in the literature with the amount and rate of endotracheal suctioning by the staff, etc. So it was a very large and extensive examination that was done by investigators, and I would like to thank them all because they did a very good job, and we had very little missing data. So obviously everyone was very keen on being careful to perform this extensive evaluation. First, we elaborated a complete score, which could seem a bit difficult, but in the end, we have, I would say, easy to find features. We were able to identify baseline characteristics as predictors. The presence of a TBI is associated with success. The presence of an intracranial hemorrhage, on the contrary, is associated with failure. The presence of hypertension or anatomical situation of the brain injury, such as the posterior fossa injury, is associated with failure. So these are non-modifiable risk factors, but interesting to take into account when you have the decision-making process of extubation. We also have plateau pressure, as you can see, some biology data at admission with pH. And of course, most important are the data we were able to identify as predictors. Again, fluid balance, a positive fluid balance was associated with failure, and higher Glasgow Coma score again was associated with success. And as you can see here, the other clinical features associated with success, as the heart rate, respiratory rate, temperature, and some items we've been discussing previously, such as swallowing attempts, visual pursuit. So in the end, they all make sense, but the score is a bit complicated, since you see there are many factors that should be taken into account. But in the end, the characteristics and predictions capabilities of this score is not too bad, because what we did is that we split the entire cohort into a training cohort with 2/3 of patients, and we left the remaining third of patients of the cohort to test the score we had created. So this is the data you have here, the AUC in both the training and in the validation cohort, which are independent one from another. And as you can see, when you have the entire score that is completed at the bedside, if the score is above 70, the likelihood ratio, of extubation success is of 3.67. So it is quite interesting to have these information in mind. But as we felt and we agreed quickly that this score could be quite challenging to be used on a daily routine basis, we proposed to we thought to elaborate the simplified score. There are only 8 items, which are more easy to use, as you can see: TBI, the body temperature, gag reflex, etc. And again, you have the characteristics of this score in both the training cohort and in the validation, but Unfortunately, in the validation cohort, the AUC could be quite disappointing, but I think we have there, I would say, a core clinical features that should be definitely looked for when we do, oh, sorry, this is a redundancy, when we you want to extubate your patients. Once again, the extubation failure is associated with higher morbidity, more health-acquired pneumonia in both the ICU course and after spontaneous breathing trials, more ARDS, more episodes of ARDS in the ICU stay, and again, higher duration of length of stay, mechanical duration, and in ICU mortality is significantly higher in the extubation failure group. But again, in all studies, these are just univariate analyses. I have never seen any multivariable analysis taking into account confounders to evaluate if extubation failure is truly independently associated with worse outcomes. So to the best of my knowledge, we are bringing here interesting information on epidemiology in extubation failure, because this is a very large international and dedicated cohort that we are able to elaborate, with both the possibility to have a learning and a validation cohort within ENIO, the ENIO network. Again, we were able to propose a systematic physical evaluation and examination of the data of extubation. So we have really extensive and I would say state-of-the-art data about clinical evaluation and data extubation. But about the weaknesses, we were not able to collect organizational factors such as, for instance, the nurse-to-patient ratio. We felt at some point that we would have to ask too many data to the centers, and we feared that the participation would be lower. So this is why some items were discarded. And there are currently some practices that are quickly changing, such as the use of high-flow nasal oxygen cannula. So maybe we will see modifications of extubation practices and therefore extubation failure rate in these patients. But regarding the last one, I mean high-flow nasal oxygen cannula, we currently have a sub-study within the ENIO cohort on the way, so we could be able to have interesting information in the coming weeks about this. If we want to summarize a bit what we know and what we can promote regarding extubation, maybe we can dig into this in the discussion about tidal volume and PEEP, but to the best of my knowledge, there are now solid data to say that we can promote a standard protective ventilation, both in the general population and also in brain injured patients. But mostly regarding extubation, there was this consensus in 2007 in the broad general ICU population. And as you know, in these patients, once you have a green light for circulatory and respiratory parameters, you may extubate without delay your patients, with a notion of adequate mentation in this consensus, which is of course a bit blurry in neurocritical care patients. And I think it is important to have both a clinical assessment of airway function, meaning the ability for the patient to secure her airway before extubation, with gag reflex, swallowing attempts, etc., and to have also a minimum level of arousal, which can be evaluated several ways: Glasgow Coma score, Coma recovery scale, visual pursuit, etc. So even if the score of the ENIO is a bit complicated, I think it's mandatory to have these two great functions to have in mind before promoting extubation. Another option about the weaning of the mechanical ventilation in neuro or in the ICU population is tracheostomy. As I said, almost 20% of patients in our cohort underwent direct tracheostomy, and never had any attempt of extubation of any kind. We found major differences across countries. For instance, in India, I think all the patients included underwent direct tracheostomy. In Italy, there is obviously, or at least there are some centers with a strong habit of performing early tracheostomy. So there are major differences across countries. And we were able to see that there are some major differences regarding baseline characteristics between the patients in the tracheostomy groups and the extubation attempt group. As you can see, there is a large rate of patients with intracranial hemorrhage. And we have the impression, and the statistical significance is here to witness this, that patients in the direct tracheostomy group are more severe. You can see there is a lower Glasgow score at baseline. There are less ICP monitoring, so definitely it seems to be a very specific population. But nonetheless, or maybe it's as a consequence, patients with direct tracheostomy have higher morbidity and higher in ICU and in hospital mortality than patients with extubation. So it's very difficult to see if tracheostomy is just an episode during the ICU course, if it is truly a risk factors for higher morbidity, mortality, or is it just the reflection of the patient's baseline severity. And when you look in the literature of neurocritical care patients, this is a meta-analysis published a few years ago, where the authors studying the impact of early tracheostomy on the outcome. And I think in the forest plot on the right, it's mostly on mortality. There aren't many studies on this topic in this specific population, but in this meta-analysis, early tracheostomy was associated with a better outcome and lower mortality. Unfortunately, in randomized controlled trials, it's a bit more tricky to know to do or know what to do. This is a randomized controlled trial performed in 900 patients. I think it was a multi-center study performed in the UK with a very long follow-up of patients after critical care admission, 2 years after their admission. And patients were randomized into an early systematic tracheostomy group and a late systematic tracheostomy group, provided investigators anticipated a long duration of mechanical ventilation. I think it was at least 5 days of anticipated duration of invasive mechanical ventilation. And very interestingly, a very modest proportion of patients did receive tracheostomy because, in fact, it was very difficult to predict and anticipate the duration of mechanical ventilation that the patient would actually display. So the intervention was poorly done because it was very difficult to predict which patient was actually going to have a very long duration of IMV. And as you can see on the Kaplan-Meier curve here, there were no statistical differences regarding survival between the early and late tracheostomy group. So it was a bit disappointing. And very recently, our colleagues in Germany and in the US managed to do this. It was kind of the same study, a randomized controlled study comparing early tracheostomy versus a standard tracheostomy intervention in stroke patients. So it's interesting because it's a very, it's of course a dedicated population with standard characteristics regarding stroke. And it was disappointing because the primary outcome, which was the modified ranking scale at 6 months, showed no difference. It showed no difference between the groups, and there were also no differences regarding the duration of sedation, duration of invasive mechanical ventilation. So the exact and accurate intervention and policy of tracheostomy in neurocritical care patients for the moment remains a bit disappointing, but there could be a subset of patients in which it is interesting. So in order to summarize this presentation, I think we are currently bit by bit filling the gap in knowledge regarding the data of extubation in neurocritical care patients. I think it is very important and paramount to promote standard of care and bundle of care in these patients with systematic evaluation of airway securement assessment and level of arousal. And we definitely need, but it could reveal challenging to promote interventional trials on this topic. And again, tracheostomy, I think it's a personal point of view. It could be very interesting, but it's quite challenging to know what should be done above tracheostomy if we have bundle of cares associated to tracheostomy that should be promoted, which patient might benefit from it. So it's quite complicated for the moment to have a consensus and to propose a dedicated intervention. Thank you very much for your attention. I'm sorry for my English, which is, as you can see, a bit rusted. I haven't spoken in years this much, but I will be happy to discuss with you now in the chat, and you will have here my email if you have any questions about this presentation.